Okay, it's 13:04 now, so I know we haven't got all the participants that were signed up to come on, but I'm sure that they will be zooming in as we get going. But it's a really exciting, packed agenda this afternoon for the webinar. So I'm Jenny Hughes. I'm the Regional Chief Midwife here in the South East, and I want to welcome you all to this South East Perinatal Equity Learning and Sharing webinar. So a little bit of housekeeping first. So if you can make sure that if you're not presenting and not talking at the time, that you're on mute, because that really helps the sound for everybody. If you want to ask a question, please raise your hand. It may be that we come to it at the end of the presentation, so don't worry if you've put your hand up and nobody comes back to you in the presentation. We'll make sure that that's picked up. Or you can put comments into the comment box, and for those of you who want that question asked, you don't need to ask it again, just put your thumbs up sign against those questions. So please do use the chat box, and I'll try and keep an eye on that, and so will Gulna as we go on through. And as you can all see probably from the tops of your screen, that this webinar is being recorded and will be circulated afterwards. So just if you don't want to be recorded, don't say anything. You can just put that in the chat box if you don't want your voice to be recorded. Okay, so the agenda today, if we go on to the next slide, first up we've got Jenny Tarter, who's talking about the service user voice, and she's newly come into our team to support us as our user voice in our perinatal equity work. We've got Kate Keane-Hicks coming with ethnic inequalities and COVID in the South East, and then Mary O'Brien with health inequalities, a regional perspective. Following on from that, we've got Paulette and Laura talking about Surrey Heartland's MVP, and then Vicky, who is our safeguarding lead in the South East on Mental Capacity Act. Then we've got Heidi Bedell, who's one of our directors of midwifery in Buckinghamshire, is going to be talking about turning the tide, the experience of ethnic minority NHS staff. And also Liz finally coming to speak to us about the South East Perinatal Mental Health Equality Strategy. And I noticed that we've got Barbara on the call too, so I'm sure Barbara will be supporting Liz in that. And then hopefully at the end we'll have some Q&A time, but if not, we'll try and shoehorn it into wherever we can. And I guess this week was the perinatal equity launch nationally, the guidance for LMS, so that's gone out to everybody. But I think in the news and through the Embrace reports, you know, the conferences have just come up. It brings it even more into sharper focus, the inequalities that we've got out there, and not forgetting that Black women are 5 times more likely to die, and that Asian women too are 3 times more likely to have issues and to be affected in childbirth. So we really need to keep that into sharp focus. And as our Afghan refugee women come into the country and are dispersed across the whole of the communities, we need to be thinking about those minority ethnic women who have extra needs and very complex needs. And I'm sure that Paulette and Laura will be talking more about that, but I just wanted to really headline that because maternity is an ever-changing scene, and we really need to keep our eyes on the ball and to the main chance. So I'm going to hand over firstly to Jenny. So Jenny, welcome.
Thank you. Thanks, Jenny. Hi, I'm Jenny Tarter. I was until September last year the Maternity Voices Partnership Chair for Mid Sussex, working alongside Brighton and Sussex University Hospitals NHS Trust, as it was then, and Sussex LMS Programme Board. I have two children who are aged 7 and nearly 4. So 2014 and 2017, I gave birth to them at Princess Royal Hospital in Haywards Heath. As a result of my experience during pregnancy and postnatally, I suffered perinatal mental health issues, which were quite serious and led me ultimately down the path to supporting other women, birthing people and their families during the perinatal period, both through the NCT and then subsequently the Maternity Voices Partnership and on the LMS board. During my time on the MVP, I came to realise the significance and importance of the service user voice to informing and shaping maternity care, and that is enshrined in Better Births. So I've just put a few quotes here on this slide, and my favourite is the one at the bottom, which is, it's not my quote, someone else's quote. But if you want to check if the shoe fits, don't ask the manufacturer or the shoe shop, rather ask the person who's wearing the shoes, because they're the ones that know how it feels for them, what it's like to walk in those shoes. And I think it's really important to get that across as part of the perinatal equity programme, because we don't need to just reach out to those who would ordinarily respond to questionnaires or surveys that we have. We need to reach out to those who won't normally respond to questionnaires or surveys for a range of reasons. Next slide, please. So I've just put some quotes here. I don't expect you to read it because I appreciate it's very short, small type on here, but these are actual quotes from our LMS, Sussex LMS's plan to implement Better Births. And I was so proud of our LMS, the extent to which they fully integrated the MVPs and underlined the importance of MVPs within and across Sussex and the trust within Sussex. And that wasn't just what they wrote on paper, they did it in practice as well, and are continuing to do it in practice. I know Sharon is on the call, and I'm not just saying that because Sharon's on the call, I'm saying it because it's genuine and that's what happened. Next slide, please. So I've just set out the definitions of co-production that's set out for NHS England and improvement guidance. There is a link there to the co-production resources if you wish to go onto those to find out a bit more if you haven't already. I've also put a link there to a YouTube video which is called No Throwaway People, and it really enshrines the importance of co-production, not just to pay lip service to it, not just to say at the end of having prepared a document or a policy, oh, please could you just cast your eyes over this so that we've ticked the box for co-production. It's about starting at the beginning with service users and working alongside them in order to implement the new area that you need to implement. Next slide, please. So this is probably the most important part of the speech, really, is around co-production in practice. And over the last 5 years, I've been involved in maternity service user feedback. I've come to learn how to do things. And I would say that when I first started as the chair of what was then the MSLC and now the MVP, most of the feedback was just done via walking the patch in the hospital. So walking around the ward and gathering service users' feedback there. And that has a value. Since then, we launched an online survey to gather and extend out our reach much further to other service users. But we also went out to walk the patch in the community. And I think this is the most important part of being able to get out and connect with those service users that wouldn't otherwise perhaps have their voices heard. And who perhaps are also affected by some of the statistics that Jenny referred to at the beginning. So the first thing, and I know that Kate's going to talk about this in a bit more detail, but the first thing is to really get to know your local population, which sounds obvious, but actually when you really dig deep, that's when you find out what's really going on within your population. I didn't know, I live in a fairly affluent area in mid Sussex, but I didn't know that we have one of the top 30% deprived communities within the town that I live in, across the country, until I started doing this work. And there are lots of issues within that deprived community, social complexities and social needs. And I think it's really important to go and do that groundwork. Look at things like your joint summary needs assessment for your local area, which is readily available. Public Health England publish an enormous amount of data and reports which set out really helpful information about what's going on in your local area and compares it to national trends. Have a look at those and find out what's going on and where you need to tailor your particular efforts for your area. And also connect with the third sector and community organisations. And I'm going to talk about an example of how I did that in a short while. And link up with your early help team, which is your children's services team, because they have contact with a lot of families who perhaps are have particular social complexities or difficulties. And I've seen that for myself because I have worked within the early help team as a family support assistant. I've seen that in practice, where you can connect and actually get out into the community and meet up with some of the service users that you might not otherwise get to meet, or who perhaps don't trust professionals and therefore maybe are more willing to speak to service user representatives. And I've just said at the bottom of that slide, you've got to walk the patch literally. Now that means that there needs to be appropriate resources and funding for your MVP chair and service user representatives in order that they can do that. It's not enough to expect them to add this to the huge amount of work that they're already doing. It is something that if you really want to connect with those who are otherwise not heard, you need to physically walk out and go and meet these people and meet third sector and community organisations who will be able to help you connect with these people. So if you can just go on to the next slide, please. I'm just going to give a few examples. So this was a poster that we put together as Sussex LMS for our trusts when we received a letter from NHS England Improvement last year to make sure that we were taking additional steps to ensure that Black women and brown women were safeguarded during pregnancy and during COVID. And we prepared this poster in conjunction with 3 service users who I managed to connect with during the time, who were pregnant at the time and who were either Black or brown. And they provided us their feedback on this poster before we released it. And what we thought was really important to do was to ensure that not only were we saying what we would be doing, but we would also say what they could do as well to help us. But we really wanted the emphasis to be on what we were doing, not putting the burden on them. And so we talked about personalised care. We also sent out letters and we offered additional telephone consultations for those women across the whole of Sussex to ensure that the risks to them were reduced. Next slide, please. So I'm just going to give a couple of other examples. I'm conscious of time, so I'm going to try and speed up the last bit. So digital examples. So last year, obviously during COVID, a lot of consultations moved over to digital platforms, and we were aware as part of our MVP that would exclude some people because they didn't have access to digital platforms, or they didn't have data or money on their phones to access digital platforms. And so we set about doing 2 things. So my co-chair in Brighton and Hove, she managed to secure a grant of £500 from the police to enable those that wanted to come in for consultations in person to come in via taxi rather than going on public transport where there was a higher risk of them contracting COVID. We also managed to secure, just through pleas to the local community, a whole range of laptops and iPads and tablets for service users to be able to use and engage in virtual consultations. And that was really helpful during COVID last year. So it's something on a practical level to think about doing. The other example that I've given there is around race and ethnicity. And one of the ladies that I talked about earlier who provided feedback on our poster had contacted me to say that during her pregnancy, when she was 33 weeks, she was taken in because she had a very large fibroid during pregnancy. And she knew about this from when she was 9 weeks pregnant, because she was taken in and they thought she might have an ectopic pregnancy, but actually it was the fibroid. And all the way through her pregnancy, when she complained about the pain, it was just shrugged off by the obstetricians and the midwives. It was just said, well, you know, it's just one of those things. And it wasn't until she got to 33 weeks pregnancy that she was told that she was at preterm risk and that she might have to have a cesarean. And this threw her into quite a lot of anxiety. And she is black, and she said it was only after she saw this that she was told that actually this was higher risk for women who were black, and she never knew that. And she thought, had she known about this from 9 weeks on, she would have probably had a bit more reassurance and been told that she was at risk of preterm pregnancy at that point. She might have been able to have coped with it much better. So that was an example that we took back, and the head of midwifery set about putting in place training for the midwives to make sure that that's something that they were fully aware of. And the final example I want to give, and I know, Golnar, you've raised your hand, so I need to be quiet, but this is an important one, which is around complex social factors. And one of my walk the patches when I went through the early help team was with a local charity that provides sheltered housing for women who have suffered childhood sexual trauma or abuse. And I met with a young lady at a housing safe house through this charity who gave me some really important feedback, and it really was profound and really very powerful. That her father had sexually abused her and had told her that she would die if she ever gave birth. And she carried that trauma with her into the labour room, but no one knew because no one asked. And she had to deal with this trauma on her own. And she also had a mistrust of professionals because of her being in and out of social care as she was growing up. And I was very honoured and privileged that she was able to talk to me. But for me to say to her, oh, well, could you just complete our survey, isn't enough. We need proper and appropriate and trauma-informed training, both for the professionals and service users who are going in to talk to these women and their families, and also for the women for them to share that sort of story with us. And that experience is really quite profound. And for me to say to her, oh, well, you could go on our digital platform and self-refer yourself to IAPT. She can't do that. She's got a mobile phone where it hasn't got any money to put any more data on it. So I think it's really important to get out there, walk the patch, meet the people that you need to meet, and get to know them and get to know what really matters to them. Last slide, I think. So I've given some other examples on the slides that you can click on subsequent to now. I just wanted to flag one of the ones which is relevant for us in Sussex. We put together a business case for a peer support programme for Black and brown women for perinatal mental health issues, because we know that there is disparities in access to perinatal mental health services for these women. And that was approved by the personalised care team of the ICS. And we have now launched a peer support programme with the Motherhood Group for the next year within Sussex to support Black and brown women. So there's work that can and should be done, and I encourage you to go and do that during the Perinatal Equity programme. Thank you.
Thanks, Jenny. And there's some comments in the box around how excellent your poster is, and I think there may be a few people pinching with pride the format and the way it's presented. So hopefully that's all right with you when we circulate.
Yeah, I'm sure.
That's great, thank you. So I'll move us straight on and we'll come back to any questions at the end of the set of presentations. So if I can come now to Kate King-Hicks, and Kate is part of Public Health England here in the South East, and she's going to talk about ethnic inequalities and COVID in the South East. Kate.
Great, thank you very much, Jenny, and to the other Jenny, brilliant, thank you, that was so good. I'm such a tough act to follow, but I'll have a go. So I want to set the scene really with a reminder of why we're focusing on health inequalities experienced by some of our communities in the South East. So can I have the next slide, please, Garner? So I know you're all aware that COVID has disproportionately impacted people from Black, Asian and mixed ethnic groups, which has provided a real catalyst for action. So Jenny mentioned it earlier, but 56% of the pregnant women admitted to hospital with COVID were from ethnic minority groups, even though they only make up a quarter of those giving birth in England and Wales. And evidence from our own disparities report suggests that men and women from specific communities were more likely to die from a COVID-related death than their white peers. There was also some indication that comorbidities such as obesity, diabetes and hypertension more prevalent in some communities associated with both severity of impact and increased likelihood of a COVID-related death. And evidence and stakeholder engagement highlighted that this experience reflected the impact of long-standing social and economic inequalities, racism, discrimination, stigma, fear, and trust. Next slide, please, Garner. So people from ethnic minority groups live throughout the South East, meaning that all of our services need to be culturally competent to enable access, reduce variation in outcomes, and optimise care. Next slide, please. But you'll know there still remains a real challenge with recording of ethnicity data and the classifications used for ethnicity. But this chart is quite helpful because it shows us the percentage of the population from different ethnic categories by the quintile of deprivation they live in, each quintile representing 20% of the population. So you can see there the Black British group has the highest percentage living in the most deprived quintile, almost double that of their white peers in the same quintile. All other ethnic groups have more people living in deprived areas when compared to the white group. And in the South East, we have 47 wards that are in the most deprived 10% of wards nationally. 21 of these are in the Kent and Medway ICS and 13 in Hampshire and Isle of Wight ICS. And that's really reflecting our coastal disparities. Next slide, please. So I only saw this yesterday, actually. This is the regional maternity dashboard that has a new tab enabling you to look at some maternity indicators by both deprivation and ethnicity in the South East. So I've just picked out one here. So this graph shows ethnic minority women and women from deprived areas are more represented in the group presenting to services with those complex factors that Jenny was talking about. We have the next slide, please. Now, bringing us back to COVID and looking at excess deaths related to COVID. So this is excess deaths in the South East, and the chart on the left shows the cumulative deaths between March 2020 and January 2021 for female ethnic groups. But it's the chart on the right that's more helpful because it shows the relative excess mortality between the different groups. And this shows that registered deaths are higher than would be expected for all ethnicities, but more pronounced for all non-white females than would be expected, and highest for women from Black ethnicities. Next slide, please. Have we moved on? Yes, we have, sorry. I missed it there. So for male ethnic groups, registered deaths are also higher than would be expected for all ethnicities, but they're more pronounced for all non-white males than would be expected, and highest for Asian men. Next slide, please. So among those deaths with COVID-19 mentioned on the death certificate, a higher percentage mentioned the following comorbidities compared to all-cause deaths, and they were diabetes, hypertensive diseases, chronic kidney diseases, COPD, and dementia. So when we're looking at this, we need to take some care, because many of these diseases are also strongly correlated with age and gender. But nevertheless, diabetes was mentioned on 21% of those death certificates where COVID-19 was mentioned. The percentage was highest in males aged 60 to 69, as you might expect, but it was also higher in all Black, Asian and mixed ethnic groups than the white ethnicity group. And diabetes was more likely to be mentioned on the death certificate of those living in deprived areas. Next slide, please. And this just suggests that the same picture was seen when we looked at hypertensive diseases. Next one. Okay, this is another example from the Regional Maternity report, the dashboard. And this graph shows the relative rates of low birth weight in term babies. And you can see here that it's Black or Black British women and women from the most deprived areas that have the higher rates than their peers. Next one, please. And I know a number of you would have heard me present these healthy indicators before. They're available through fingertips, but I thought it would be worth repeating. So in England, so these are England rather than regional rates. So in England, women from Black or Black, Asian or mixed ethnic groups are less likely to take folic acid supplements or access maternity services early, reducing the time available for that early intervention and management of clinical risk. And poor performance of these indicators also correlates with high rates of deprivation and women who present with those complex social factors. Next one, please, Golna. And in England, 33% of women from Black ethnic groups are obese at booking, compared to 22% nationally, increasing their and their baby's risk of complications during pregnancy and birth. Obesity in pregnancy also correlates with high rates of deprivation. However, there is better news in that pregnant Black and Asian women are less likely to smoke in early pregnancy. Just a couple more slides then from me, Golna. So it's important to remember that the South Asian population living in the UK are up to 6 times more likely to develop type 2 diabetes than the white population. And people from African and African Caribbean descent are 3 times more likely to have type 2 diabetes compared to their white peers. And so we know that many of these comorbidities are preventable, and severity of their impact can be reduced through risk identification, effective clinical management and supported self-care. Excuse me. But there's also action to take on the underlying causes of these diseases, such as stopping smoking, improving diet, reducing sedentary behaviour and enabling people to live more active lives, addressing the wider determinants of health, such as poverty, low income, poor housing and educational opportunities, and supporting individual and community resilience and wellbeing. And just one more from me, Golna. So there's a wide range of partners in our integrated care systems, and I think we all have a role to play in addressing disparities in health outcomes for our minority ethnic communities and workforce, including action to address those behavioural risks and other wider determinants. So this is a really helpful infographic because it just kind of shows everybody's role, really. So local authorities can promote population lifestyle programmes and use their licensing powers, for example, to restrict the density of food outlets. GPs can refer to the National Diabetes Prevention Programme, and through social prescribing to community support. Pharmacies, they can give advice on healthy lifestyles and deliver health screening. And in the community sort of settings, there are opportunities to promote healthier workplaces, work with our leisure services and food retailers. And I think I'm now passing over to Mary. Thanks.
Thanks, Kate. Great presentation. And now statistics stopped everybody in their tracks. It's compelling, isn't it? And nobody can argue with those numbers. It's really quite sobering. So everybody, those of you that are part of LMSs and maternity services will have access to that data that's on the collaboration site, the NHS Future site. So if you haven't, contact us and we can get you access, or contact your LMS PMO and they can help and organise that for you. But that is all there for you to access, but we'll get that circulated round. So I'm going to welcome Mary now. Mary is Deputy Director for Strategy and Transformation and has been working in equity, and is going to talk today about her role in the South East.
Thanks very much, Jenny. So my presentation really summarises the NHS E&I national and regional context for health inequalities. So really the policy and the strategy context for driving the health inequalities agenda. So taking account of those pretty shocking statistics that we just heard from Kate, you know, how does that actually then translate into action? So this is what I'm going to cover, just a bit about the national team, because that's restructured and we have a new national director now. An overview of the current planning guidance and what that means for health inequalities. Just touch on 5 specific priorities: elective recovery, news about a national dashboard on health inequalities that's coming, a new initiative called Core 20+5, and then just I've got a final slide about some available support. So next slide, please. So we a few months ago got a new national director for health inequalities. Her name is Dr. Bola Olawabi, and she's a GP as well. And I have to say, I think she's got to grips with the agenda really quickly, and she's done fantastically well to make sure that health inequalities have been, you know, woven through the planning guidance. So it's not just something that happens separately somewhere else. You know, it needs to be part of what everybody is doing. So I think in a very short space of time, she's pulled the national team together and really tried to define the approach. And I won't read it out, it's on there for you. But I think it's helpful as well to think of the role that the NHS plays in terms of reducing health inequalities at 3 levels. So we're a commissioner and provider of healthcare. You know, we're a partner with our integrated care systems. And something that's gaining increasing prominence, which is a very good thing, is the NHS as an anchor institution. So what are we doing as an employer in the community to help to reduce inequalities? Next slide, please. I won't go through all of these. There's quite a short, actually, 20 pages, I think, this year for H1 planning guidance that you can read to see where inequalities is woven throughout. And as I say, I think what's different this year in the planning guidance is, you know, there is a section on health inequalities, and those are the 5 that I'll come on to. But actually, when you read through it, you know, it is actually through elective recovery. You know, the long-term plan deliverables are re-emphasised again. You know, as Kate mentioned there, you know, it's still important. Smoking cessation, weight management, expansion of the diabetes prevention programme and CVD prevention. And actually there's also a primary care network, DES, coming that's very focused on CVD prevention, so targeted hypertension case finding. So again, just this whole theme of trying to weave it into things. Reducing unwarranted variation across pathways as well. So actually looking at patients' experience of care and what does that look like when you look at it through a deprivation lens, through an ethnicity lens. Workforce inequalities, RES, absolutely up there as well. The health and care role in economic recovery. So again, the NHS as an anchor institution, you know, what are we doing in terms of how we employ people, especially people on our lower paid wages who do tend to be from ethnic minority and more deprived communities. There is a lot that can be done. I mean, there's a very good example of a trust in London who just had a look at all of their 0-hour contracts are, you know, basically less than optimum contracts they had, and they could see a real inequality there. So they basically just took all those people and put them on a permanent contract. Now that has absolutely cost that trust money, but I think it's a really good example to say, do you know what? Sometimes you've got to put your money where your mouth is. If you think this is important, you've got to do it. And that has made a massive material difference to those employees and their families. Next slide. Great. Health inequalities. So these are the 5, and actually hopefully you'll recognise these, because last August, when we had the NHS phase 3 response to COVID, there were 8 urgent actions on health inequalities. They've sort of reduced them down to 5, and these are also included in the guidance that has just come out, actually, the Equity and Equality Guidance for Local Maternity Services. So they're re-emphasised within that guidance with a focus on maternity. But I think what's interesting, when I was looking at that guidance and thinking, yes, okay, this is all about maternity, actually, I think the value of it is that hopefully addressing these things helps women, beyond their maternity experience, so things about restoring NHS services inclusively, mitigating against digital inclusion, very important for maternity, but actually for lots of other things that these women and their babies will need to access in future. An important one there, and it is expanded quite a bit in the maternity guidance, accelerate preventive programs that proactively engage those at greatest risk of health outcomes. And maternity does get a mention there in the sort of standard planning guidance, but of course it's expanded much more in the maternity, the equity guidance. And I think a really key one there for the NHS is strengthening leadership and accountability around health inequalities, because again, I think in the past it has been a bit siloed, a bit, I think Jenny was talking earlier about public participation. Very easy to just say, get somebody to have a look and say, have we ticked the box on this? And I think historically there have been cases where inequalities has been treated like that. Yes, we care, but have we done enough, without it being really, led properly? So a big emphasis on leadership, and the national team are putting together a lot of development programs for leaders in trusts and other NHS organisations around that. Next slide, please. Oh, yeah, next slide, thanks. There is a big focus on elective recovery at the moment. I know this is not particularly of huge interest perhaps to maternity at the moment, but it's such a massive pressure for the NHS, and I am reassured to see that inequalities are getting a profile there as well, because I think in times gone by, if we had pressure on elective recovery, it was just get the numbers through as quick as you can. That is the priority. And to be honest, it still is. But there is an absolute requirement to understand your waiting list data and make sure that you're not actually increasing the disparities. You need to be reducing the inequalities. So there's been some very good work that North Central London did, proper regression analysis, to understand what the differences are in waiting lists. And I've been encouraging our systems to do that. I have to say, the problem is not really once you're on the waiting list. The problem is getting on it in the first place. If you're from a more deprived population, certain ethnic groups, you're actually more likely to be late presenting, all of those things, more likely to, in some cases, to have a worse experience of care and consequently a worse outcome. So those are the areas that really need the attention in all of this. But while I'm not usually a fan of the whole assurance sort of role, I think here it is actually very helpful at the moment in terms of elective care, in constantly reminding trusts that they need to be doing this. Next slide, please. Now, when I did this slide, it says Health Inequalities Dashboard launching today. So I was on the launch meeting this morning, and who'd have thought it? It's an IT platform that's been delayed a little bit. So there we go. But they did tell us that it'll be this month. So national dashboard, which I think will be useful to show us some high level disparities. So these are some screenshots from a very, very early test version of the dashboard. It does look slicker than this in real life, but I know you can't kind of see all the detail there, but this is just showing us, virtual appointments by ethnicity and deprivation. And And just to remind you, one is the most deprived down at the left-hand side there. And there are real differences in those most deprived groups, particularly for Black and mixed Caribbean groups. So there is a divide there. Next slide, please. This is just another example showing proportion of patients with SMI who have received an annual health check. And you can see here, just at a regional level, the Southeast, unfortunately, we're down there near the bottom, just at 18%. If you compare that with Northeast and Yorkshire, 32%. So we would obviously want to look into that in more detail because there'll be variation within the region. But basically, it is flagging up things we need to be looking at. Next slide. Sorry, can you just go back to that one, Gunnar? Thanks. Yeah, sorry. So this is the breakdown. And I should say that I don't want to name and shame, but Frimley are up there at the top doing pretty well. But unfortunately, quite a few of our systems are in the bottom half of that profile. So there is something to be looked at within the same region. Why would we have such a variation? Next slide, please. Okay, so this is just to flag to you something else that's coming, and the national team are hoping to get it into the H2 planning guidance, and it's an initiative that they're calling Core 20+5. So it's really building on what already exists and building on the long-term plan. So the Core 20 refers to the most deprived 20% of the population. So, IMD 1 and 2, but also, bearing in mind those populations who may not be traditionally linked in with health services, so inclusion, health and homeless as well. The plus refers to another population group as identified locally. So, it might be coastal communities, it could be particular ethnic minority groups or people who have a particular challenge. And then the 5 is targeting 5 key clinical areas for health inequalities. And again, these things are already in the system, as it were. So early cancer diagnosis, of course, that's a priority. Hypertension case finding, I mentioned already, there's a PCN-DES coming on that. Chronic respiratory disease, that's been flagged, especially because of COVID. Health checks for people with SMI and continuity of maternity carer plans. And of course, that's already in the maternity guidance as well. But I think it's giving it that extra profile, and it's saying, actually, we're asking you specifically for those most deprived population groups that you've got. How are you doing on that? So I think it's going to force systems to just do that extra sense check. Hopefully they're already doing actually most of it, but is it being targeted in those who need it most? Next slide, please. So this slide is just trying to illustrate how the Core 20+5 is already sort of linked in with those 5 urgent actions on health inequality. So they all should go together. Finally, then, there are some webinars available to support the key planning guidance priorities, so those 5 urgent actions. This was circulated to systems, but if you haven't seen this and if you're interested in joining any of them, please, I'm sure the slides will be shared and you can just click on those links and book yourself in. So that's all I wanted to cover, Jenny.
That's brilliant. Thank you so much, Mary, and work to do right across all our population, and it's a make suring that we all amplify where we need to so we get our women and their families in the right place with the right care and outcomes. So that was really great. Thank you for giving us that context. And I know we'll be clicking on those links. So thank you for that. Thanks, Mary. So if I can move us on then, and I'm going to welcome Laura Weatherall, who's going to talk to us around the Surrey and Sussex Hospitals MVP work around migrant and asylum seekers. And I know Paulette's supporting too. So if I can hand over to Laura and Paulette, thank you.
Thank you. I'll just do the introduction, and so thank you so much for giving us an opportunity to present on this platform. I have got a slide which will show some of the highlights really in terms of what we're doing with the Surrey Heartlands, and that will be circulated. It supports this presentation that Larry will be doing. She's Laura, but she does like to be called Larry as well. So just to really give you some highlights in terms of what we're doing in Surrey Heartlands. I heard today about leadership support, and we do have buy-in from the ICS, our Integrated Care System, in terms of the assurance piece around what we're doing in terms of health inequalities. We've got 4 established Maternity Voices partnerships, and that includes ambassadors. So we do have some MVP ambassadors. One of them focuses on the work around health inequalities. They're involved in walking the patch and supporting survey work and focus groups as well, in terms of just gleaning what we can get in terms of the experiences from our women and their families. We've also got midwives who work with vulnerable teams, so Ashford and St Peter's Hospital, and within their patch there is the prison, and they've got midwives working with them as well. We also have focus groups. So one of our areas, that is Epsom and St Helier, they have been really involved in terms of focus groups working with Black, Asian and minority ethnic groups, really just to understand the experiences that they've gone through in terms of accessing maternity services throughout the pandemic. And they've just been shortlisted for a Nursing Times Workforce Summit Award, and that involves some of the work that they've been doing, so that's really positive. We're really involved in terms of the managed quarantine services and asylum seekers support work, and that's what Laura's going to focus on today. We've got the comms and engagement plan. We've been working in terms of just making sure that the information that we portray in terms of our leaflets, that we've consulted our Maternity Voices partnerships, and that we're working with our service users on that as well. The pregnancy advice line is there, and that's another area where we're really just trying to make sure we've got that inclusion piece right in terms of that early access as well. One of the other key areas is around the ethnicity data, and there has been some work done in terms of just really improving the processes and systems in terms of how our workforce record the data, and then how we can actually get the information that we need to see what do we have in our population in terms of the various groups and how are we supporting them. There's also work done around the health and economies, and that's in SASH area, just trying to look at some of the continuity of care outcomes, and that's work that's ongoing at the moment and will feed into the health and equalities agenda as well. And we are in the process of recruiting an equity lead that will support some of this work right across the system, and we are also working really closely with our charities and the Surrey Minority Ethnic Forum to support us with some survey work and questionnaires, just to really understand the impact of the pandemic on our service users, and working with a charity that's actually doing some work right now with South Asian women as well. We are also really keen on making sure the work is streamlined across our work streams, and so all the interdependencies in terms of the health and equalities work stream, first 1,000 days. I heard someone talk about early years. That's something that we're doing as well, mental health, maternal medicine network and so on, and really making sure that the safety agenda is pivotal in all that we're doing, and that we can actually look at the disparities from that perspective as well. And we've got a task and finish group that we're setting up that we launched this month to focus on this piece of work as well. So that's just a whistle-top tour in terms of some of the work that we're doing, and I'm now going to hand over to I'll say Larry, because I know you prefer that, Larry, to go through the work on the asylum seekers and the managed quarantine hotels. Thank you very much. Thank you.
Thank you, Paulette, and I hope that you can see the presentation on Gulna's screen. So this presentation is entitled Supporting and Listening, and that's precisely what we've aimed to do, both support and listen to maternity services as well as the women who we're serving in our area. So we're thinking specifically today about caring for refugee and asylum seeking women, most of which our care has been focused on the women who have come to us from various different Home Office designated accommodations, and so thinking very specifically about those women. which is why this has got such a narrow focus. So this is really an opportunity to encourage excellence in woman-centred and personalised care. And what I'm hoping to do today is just give you a couple of actions for almost immediate use if you're experiencing caring for these women in your area, and also some insights from our feedback that we've had from women. So right at the very beginning, when we found ourselves in the area where there were a sudden influx of women who had come via the Home Office. They stood up a hotel with 75 women who, about 20 of which were pregnant at the time. And so we knew that there was an immediate need. And so our maternity services involved us straight away, right from the get-go. And I firmly encourage that to happen. Next slide, please, Golna. Brilliant. So we quickly created this inclusive and accessible visual for midwives to take around and show to women. It's very simple. It's easy to understand. There's not too much in the way of information on there, because we realised that the most important thing is to build trust rather than to bombard women with lots of different information. So they were able to use this. We networked as an MVP with local food hubs and baby banks as well to gather information and offers of support. And then we fed that back through to the LMNS and also directly to SASH Maternity. And we were able to immediately recognise that getting access to these women to find out what the needs were and what they might need from maternity services was very limited. So we used our kind of agents on the ground, which were Care for Calais at that time, and really tried to find out exactly what these women needed and when they needed it. And so then we attended lots of local government meetings and third sector meetings just to try and understand exactly where that support was required. So so next slide, please, we can crack on. We, as an MVP, have done a new media project which has involved plenty of videos for which we did specifically with those with low literacy and for women for whom English was not their first language. So we've done tours of the birth room and theatre and you know, explained in very simple terms the kind of care that they can expect to receive at SASH, the aim of which is just to give people familiarity and understanding of what that care, compassionate care, might look like. And so we've worked directly with Happy Baby Community, who are a third sector partner in the area who've been commissioned for perinatal support. And so we're meeting with women on a one-to-one basis when we know that they're going to be accessing care with SASH, and supporting them really the whole way through their journey, whilst for the time that they're with us, bearing in mind that we're expecting them to be moved on at any given moment. We're sharing information with them to increase engagement. We understand that many of these women will be completely confuddled as to why they're having so much antenatal contact, and so it's about reassuring those women that that it's not about surveillance, it's about caring for them and doing what's really supportive for their pregnancies. And the most crucial thing that we've done, I think for SASH specifically, is connecting ourselves with SASH Maternity on a very, very, very regular basis. So we have a continuous feedback loop with maternity services where we're really communicating the live experiences of women and adapting the service provision according to that. So not waiting until we've had 6 or 7 or 8 women that have gone through the system to find out what the concerns are, meeting with women on a one-to-one basis to try and support them and feeding that back, and then having a service adaptation. So as an MVP, we're also finding small ways to show that we care and that we have a desire for equity. And one of those ways is through birth affirmations. These ones are in Albanian, but we also have them in a wide selection of languages, and all of which are have been tailored according to the languages that we've used. We can move on to the next slide, please, Garner. Brilliant. So we're also identifying areas where asylum-seeking women might just fall through the cracks and trying to mitigate for those risks. And so one of those risks, for example, is where women may have just come straight off. So for example, we've seen this very, very recently with Afghan women who have come straight from transportation from Afghanistan. They've arrived with nothing but the skin and the clothes on their back, and so we wanted to find ways as an MVP to support these women. And so British Baby Box donated to us a number of these newborn cribs, and our local baby bank has been amazing in populating those boxes, just with hundreds of pounds worth of provision for these women, so that they can take that with them. And the great thing about these boxes is that everything can pile in for them, because we know again that these women are quite likely to be moved on very quickly. Already the first woman who we've spoken to has been moved on from our area up to Luton. So we know the impact of these boxes specifically and how incredible they are. And as it happens, just as a practical side note, I spoke with British Baby Box this morning, and they're willing to offer a box to every trust within the southeast area. So if you find yourself in the same situation, you're very welcome to contact them, and they will be very happy to send you one. So next slide, please, if we can. And this is just about the insights, this slide here. So practical points which the women and their supporters have shared with us. So first of all, things like allowing women to lead, asking questions tentatively, specifically thinking about the booking appointment, watching their body language as you ask questions, asking questions like, would you like to discuss the health of the father, or would you like to leave that question? So that bears in mind that not all women have chosen the pregnancy, especially if they're coming through human trafficking, that this may not have been their choice. They may have tried to abort this pregnancy. And so just being really very careful, and that extends to intrapartum care as well. So thinking about relationship first and then clinical care, you should expect submissive and over compliance from these women, and then obviously develop mitigation strategies against that, because human rights are more important than ever, the dignity and autonomy, and especially informed consent for these women. And obviously that brings very, important challenges with translation services. So live translation is the gold standard. Then after that, thinking about things like Language Line, and then after that, apps like Card Medic are useful. Thinking very carefully about triggers for blood, bright lights, darkness, touch, male clinicians, and using language like, waves, for example. We like to think about waves of contractions, but instead of that, think, obviously, if you've just crossed the channel, that's going to be a triggering piece of language. So thinking about that. In Afghanistan, for example, 1 in 150 mothers die in childbirth. So these women may well be bringing additional fear into the birth space. And so we need to remind ourselves of that as well. And I think someone just mentioned in the chat a little while ago, was it Mindy, who was talking about breastfeeding, again, being aware of cultural norms. Exclusive breastfeeding at 6 months is 58% in Afghanistan in comparison to 1% in the UK. So thinking about those cultural sensitivities as well, allowing things like additional skin to skin and breast crawls, etc. And probably the last thing for me to leave you with is arranging third sector responses before discharge, and offering transportation home. No woman who is an asylum seeker should really be worrying about her taxi fare home. And so one of the things that Sasha's agreed to do is pay for that that transportation home from the hospital and discharge. And it's just about finding small, tiny ways that we can support these women on a regular basis. Thank you.
Thank you, Larry. That was brilliant. Great poster and fantastic compassionate care, both clinical and pastoral. So really great, thank you. And some good tips. We all like a freebie, and if we can get them out to those women, that's brilliant. So thank you. Right, I'm going to move us quickly on because we've got 30 minutes and we've got 3 presenters, so we're on a bit of a timeline here. So if I can introduce Vicky Gray. Vicky's head of clinical quality safeguarding here in the Nursing Directorate in the South East, and she's going to talk about the Mental Capacity Act. Vicky.
Thanks, Jenny. I'm going to try and do this within the 10 minutes. So I'm watching the clock. So some of the slides in here will be for information afterwards, because we just don't have the time to really get into all of them. So if I can do the moving on, that would be great. Thank you. So this is about the fundamental principles of how we practice. This is about people's consent and their rights, their human rights, and the importance of practitioners being really clear about how they obtain valid consent, and where they can't obtain consent for something. The legal framework of the Mental Capacity Act is what supports and protects professionals as well as patients and the public about how we practice. So it's starting off really, the Mental Capacity Act's been around for a really long time, 2005, and we've still got some improvements to make about our understanding and application of that. So I'm going to talk really mostly today about deprivation of liberty, but we're going to go, if we can have the next slide, we're just going to go over some very basic points. I'm not going to go through all the statutory principles of mental capacity, but just for the purposes of today is to really focus on the presumption of capacity, that we are all presumed to have capacity in the eyes of the law. We're all equal in front of the law in that respect. But where we do start to wonder if our patient has capacity, it's just being really focused on that support in the first instance to help them make a decision. Going back to the previous conversation from our colleague there, you know, it could be something like an interpreter or a hearing aid, or something that helps somebody with their speech and language, or another person, a family or a friend, that helps somebody understand information. So before we rush to an assessment of capacity, it's just about how we've demonstrated we've really supported that person to make their own decision first. And just skipping over the others is just to be really clear that when we are putting restrictions in place, when we have to, that they are absolutely the less restrictive option we can possibly do. So moving on. And again, the mental capacity is time and decision specific. So we don't say somebody lacks capacity, we say somebody lacks capacity in what. So it's just been really clear in documentation and our conversations that it's not a global assessment of cognition. This is about individual decisions in different times that might change. People fluctuate, particularly in maternity. People may lose capacity and regain it due to things like infections, for example. So moving on. So the capacity assessment itself, again, not really the purpose of this presentation, but just to go over it and make sure that the slide is there, is just being really clear that where we do have supported the patient and we're still concerned that they're not able to, they might not have capacity, is the assessment involves ensuring that in that particular decision you want made, is does the person understand it? Can they retain the information long enough to make the decision? Can they use and weigh it? Can they look at the pros and cons? And can they communicate their decision? And then if you're finding no to any of these things, then the person lacks capacity. And that must then correspond with them having a disturbance of the mind or brain, temporary or permanent, that affects their ability to make this decision at this particular time. And let's just be really careful that we don't set the bar higher for these patients that we're concerned about than we would for anybody else in terms of what they need to understand to be able to be considered to have capacity. And make sure that we are reviewing capacity assessments as regular parts of our patient reviews. So moving on, if our patient is deemed to lack capacity, then there is a best interest process about how you make decisions. I'm not going to focus on that now, but I'm leaving the slides here to look at afterwards. And it's all set out in the Mental Capacity Act Code of Practice about the best interest process. And how the patient must be really central to that process and those who can advocate for them. So we're going to move on to a deprivation of liberty. Now, you cannot deprive somebody of their liberty using the best interest process. It doesn't extend that far, neither do powers of attorney. So if we move on, liberty, our right to liberty is a qualified right. We have it, we all have it under Article 5 of the Human Rights Act. But it is a qualified right, which means that it can be something that is not an absolute right. It may be taken away. So it can be taken away under the Mental Health Act, under the Criminal Justice Act. recently we've all had a small taste of it being taken away under the Coronavirus Act to some extent, and under the Mental Capacity Act, which has now changed recently to the Mental Capacity Amendment Act, which we are expected to be enacted in April next year. So that's going to change the current Deprivation of Liberty Safeguard Scheme to a new scheme of the Liberty Protection Safeguard Scheme. So just to talk about what deprivation of liberty is then under the Article 5 Human Rights Act, is that a person is confined to a particular place for a non-negligible period of time. So you're talking about your patient on the ward, for example, who is confined to that place. They're not allowed to leave, and they may be subject to restraints in order to do that. So a non-negligible period of time in the law can be as short as 20 minutes, depending on the intensity of the restrictions that are in place to keep that person there. They cannot consent to that confinement because of their lack of capacity that we just talked about. They're unable to provide consent to be confined. And that deprivation of liberty is known about by the state, so it's imputable to the state. So it's not necessarily even that the state is conducting that deprivation of liberty, but if the state knows about it, then it is imputable to the state and they have a positive obligation to do something about it. And as midwives, nurses, doctors, anybody who works for the NHS, we are an agent, therefore, of the state. So if we know about something as professionals, then that means it's imputable to the state. And if we know about this happening, then it is necessary for this to be authorised. So if it's not authorised by the Mental Health Act, the Criminal Justice Act, then we need to be looking at, well, what is this care authorised under, which is where we look at a deprivation of liberty. So moving on. So as I say, just to clarify that, the person must lack capacity to the arrangements for their care. They must not be under the Mental Health Act, and they must be deprived of their liberty under their best interest to stop them from coming to harm in a proportionate response to the seriousness of that harm. And that is where you seek an authorisation for a deprivation of liberty. So, so moving on. So the key test for us then when we're working with patients is to ask ourselves, is that person subject to continuous supervision and control through the care that we're providing? Are they free to leave this environment? If they, and that's regardless of whether they're trying to leave or not. It's in theory, if they did try to leave as staff, would we stop them? Would we stop them from trying to leave? So it's not about their physical ability to leave. They might be saying they'd like to leave, or they may be acquiescing. But actually, if they did try to get up and leave the ward, for example, would we try to stop them from doing that? And then that person's not able to consent to the arrangements that we've put in place. If that happens, then they are deprived of their liberty. So moving on. So some of the questions. So this is about being deprived of your liberty in your own home. At the moment, the current DOL scheme applies in the hospital, in the acute hospital, and it applies in care homes only. Anything outside of those environments needs to be authorised by the Court of Protection. The new liberty protection safeguards that are coming in will extend to patients' own homes during their care. It will also extend to transport that takes them from one place to another for care and treatment, and it will apply in the hospital. But instead of the local authority, you applying to the local authority for a deprivation of liberty safeguard authorisation, the liberty protection safeguard, the big change for the NHS is that the acute hospitals will be authorising their own deprivation, their own liberty protection safeguards for that patient based on the care plan for that person. So that's the sort of main change, is that this is going to apply to people at home and in the community, and it's also still going to apply in hospital, but the hospitals are going to be responsible, acute hospitals that is, for doing their own authorisation processes and being able to demonstrate robust arrangements to be able to do that and review them, and that's going to be inspected by the CQC going forward. So the kinds of questions that we're asking around whether somebody's deprived of their liberty, the sorts of things you need to be thinking about is, are they prescribed and administered medication to control their behaviour, including PRN medication around sort of sedation, controlling behaviour? What level of support and restrictions are around their activities of daily living? And is that support provided on the patient's terms, or is it imposed on the patient on the care plans, on the staff terms that it's been set out by? Are we using technology to monitor the individual at home or in any care venue and monitoring when they leave? Are we looking at regular use of restraint in their care plan? And it's not to say that any of these measures might not be necessary for a person. It's about being really clear and documenting them and reviewing them if we feel if that's what's happening and they're not under an authorisation. Are they at home? Are they in an environment where the door is locked or they're prevented from leaving? Are they free to come and go? Are they regularly locked in a room or an area of their own home or on the ward? And are there lots of restrictions placed on them, or any restrictions by professionals about who can visit them and who can see them while they're in that care venue? So moving on, did somebody want to ask a question? It's quite a big topic to cover in 10 minutes, so apologies.
It's the same time up, I think, from Gulna.
Yes.
So if you could just wrap up for us.
Oh, yes, of course. Yeah. Move on. So very quickly then, let's whiz through. So yes, looking at chemical restraints, physical restraints, any financial restraints on that person, and the equipment that we might be using, like sensor mats, alarms, anything that's restricting that person. They may have a learning disability, they may have another cognitive impairment that we need to restrict or restrain that person for. So moving on. So as I say, it will be in all settings. It'll apply from 16 plus rather than 18 plus, as the deprivations of liberty are at the moment. And as I say, the hospitals will be responsible for approving their own, authorising their own deprivation of liberty protection safeguards in future. Moving on again.
Yeah, moving on.
Just go back one, sorry. So yeah, so we will be doing our own assessments based on care plans, based on a medical assessment to diagnose any kind of impairment or disturbance of the mind or brain, a mental capacity assessment, and making sure that the care that is in the care plan for that person is necessary and proportionate. The next bit is really important, so I'll just do that and then we'll wrap up, is training and resources, forms and data. So the training is going to come centrally from Health Education England, and that will be rolled out nationally. There is a business case in from the Health Service to the DHSC to look at funding for all 7 regions to support the rollout of the liberty protection safeguards. So there will also be forms and templates and things that will be shared out nationally, but that doesn't negate from the need now to comply with the law and make sure that we are documenting mental capacity assessments in care plans, and that our staff feel confident, supported, and trained and skilled in able to deliver their responsibilities under the MCA. And there is NHS Digital are developing a national database to monitor deprivation of liberty. And the point I'd make now before we have to wrap up and you can see the slides is that this database will enable us to look at the demographics of who is actually being deprived of their liberty in care settings. So we'll be able to look at ethnicity, we'll be able to look at gender, we'll be able to look at departments, is where are people being deprived of their liberty. And when we can start to really analyse and think about that data, it will enable us to think about how we can practice in less restrictive ways and lead to some of those innovations and drive up quality, particularly for our most vulnerable people that we care for. So this is really about making sure that there are clear safeguards to protect people who lack capacity and are cared for under restriction. It's about making sure that our staff are protected to practice in that way under a lawful authorisation. So we are still on track for April 2022 for this to come in. We still don't have a code of practice, so I can't give you any more details on how the LPS is going to work at the moment, but please do keep in touch with your mental capacity at Leeds. We have a regional network that's meeting frequently, and they will be able to give the downloads to maternity, and we give them to our maternity safeguarding regional network as well about what this is going to mean for maternity, and give them some case studies around that as well. So any questions?
Great. Thank you, Vicky.
Sorry,
it's fantastic.
And
the slides will be going out, so everybody will have your links and to see the full presentation. But really great to put that on for us. So thanks so much. I know it's a massive subject to get into.
It's a huge subject to tackle, isn't it? But like I say, yeah, just get in touch with us if you'd like to ask any more questions.
Yeah, that's great. Thanks, Vicky. Thanks so much. You know where she is now, guys. Get in touch with her.
Please.
Okay. So we're going to have a little bit of a rejig of the agenda. So Liz is going to do her presentation next time with Barbara. So I'm going to introduce Heidi Bedall, who is Director of Midwifery at Buckinghamshire, as I've already said, Dr. Gloria Rowland, who's Chief Nurse West London CCG, and have we got Tosin here as well? Yeah, and Tosin, Maternity Digital Transformation Manager. And Tosin, apologies, I've dipped out of saying your surname just in case I get it wrong. So you could tell everybody just how exactly it should be said. And thanks very much, Heidi, particularly coming from the clinical area, because I know how pressured you are at the moment. So thanks. And over to you.
Thanks, Jenny. Good afternoon, everybody. Thank you for the opportunity to share the Turning the Tide work with you all. And before starting, just really to acknowledge the visionary leader behind this, which is Dr. Gloria Rowland. And unfortunately, Gloria hasn't been able to join us this afternoon because she's presenting the same work in Birmingham. So that's great, because that means we're really percolating this work out across the country. So it's with great pride that Tosin and I are representing her and the team that we're part of. The Turning the Tide report was published in October 2020. So amongst the pandemic, you know, this was published, and we want to bring attention to it because we recognise that a multitude of reports came out the back end of last year, and this is one that we really need to be on everyone's radar, especially at a time when the equity strategy is being launched. So I'm going to hand over to Tosin to share the origins of the work, the approach, the key findings, the recommendations, and then I'll come back to you with what actions we've taken and the next steps. Thanks, Tosin, over to you.
Thank you very much, Heidi, and thank you everybody for the invitation. It's a pleasure to be here, and again, in the absence of Dr. Rowland, I'm very I'm honoured to be here to present this with Heidi. So my name's Tosin Ikobayo. I am the Maternity Digital Transformation Manager at the North East London Local Maternity System, and I'm here speaking today because I was at the genesis of this work commencing. So I think I know a little bit about the background and how it's all evolved. So very mindful of the time. I think we'll just whisk through this, and I'll hand over back to Heidi. So I think as we know, at the peak of the pandemic, the COVID-19 was something that was very unknown to a lot of us. It was a struggle within the healthcare setting because we just didn't know what we were dealing with. We didn't know how to react to what was faced with us at that time. And it was a vision of Dr. Gloria Rowland to try and establish what the experience of our staff were as carers and as well as persons, as people, to see how they were doing within the clinical area. And so our approach was to channel specifically at our ethnic minority staff to see, understand and manage their misconceptions around the experiences, the care provided, as well as the social cultural influences that was faced by staff themselves, and how it influenced the care that they provided, as well as PPEs, protective equipments as well. So that was really the reason why we started this in the first place, and it unfolded a lot of layers which we didn't realize, a lot of things which actually was about time it came to the limelight, really. And so if we just go to the next slide, please. So we, Dr. Rowland contacted all the HOMs and DOMs within England, and it was interesting that there were only very few ethnic minority HOMs and DOMs across the country, and even that in itself raised some awareness around, you know, is there equality around our workforce and our board and leadership teams within maternity. We then went on to conduct a virtual forum. So we had 11 virtual forums starting from the 18th of May to the 30th of June. We had over 334 maternity staff which attended, from band 5s right up to band 8s. We had a huge interest as well from medical staff within primary and secondary care settings, and everybody were interested in this platform to express their experience that they have had. Those who were not able to attend were given the opportunity to complete a survey. So we had over 132 responses. And like I said, we had 2 main areas of discussions, which is around risk assessment and personal protective equipment. Next slide, please. The key findings we got from these forums were that, like I said, all ethnic minority staff were represented at all levels, and it was interesting to find that we had different challenges faced from different level of staff. So we had senior management staff, we had those sitting on executive boards, which talked about their own personal experiences in terms of myths that they have faced, or that are facing that's actually influencing the care that they provide into the women in the clinical area, and how we can debug those myths. That included self-medication at home, herbal medicines, which actually was a huge influence in the information that were provided by clinical staff to our women. There were reluctancy around COVID vaccine hesitancy. As we know, there was a huge lower uptake amongst ethnic minority staff compared to the rest of the general public. So there were emphasis as to why, what were the reasons why exactly. And a lot of conversations came around the misconceptions that we have and misinformation that are given, and the information given within the community, such as churches and other community support systems. So a lot of rich conversations came out, and I'm going to hand, actually, yes, I'll go to the next slide actually, and we'll talk about how and what we did with this information. So the report was launched and there were over 30 recommendations, but we found that there were key recommendations that we felt we had to place some actions on. So firstly, around regulatory bodies, secondly, around getting involved with the multidisciplinary teams, such as obstetric and nursing staff as well. Next slide, please. Also in terms of career development and improving healthcare and outcomes for ethnic minority women. And next slide, please. And also establishing networks that were non-maternity, so from general size as well, getting involved with CQC, the RCM, the NMC, working collaboratively with external organisations such as the London MVPs. We had 5 times more who were represented as well in several forums which we had, again, which generated very rich discussions in the forums. So these recommendations were then divided into work streams, which Heidi's going to go further on and talk about. So at this point, I'm going to hand over to Heidi, mindful of the time. Thank you, Heidi.
Thank you. I am watching the clock. Do give me a wave, Gulna. So as Tosin said, that the report was launched, and we identified key work streams, and although there's 6 recommendations, we made 7 work streams because some of them are huge in terms of their content. I'm delighted to be working on 2 of the work streams along with my colleagues, and it's really timely, as I said, in the sense that the National Equity Strategy has been published, and the Turning the Tide group have got an advisory capacity to the Chief Midwife Officer for England and her equity lead, and that's a relationship that we've established thanks to the work of Dr. Rowland. Since the launch, we have optimised as many opportunities as possible, this being one of them, to promote the work. And at the launch event, the invitation for expressions of interest went out for people to become involved in this project. So I wasn't part of the original team, as my colleague Tosin was, but when I heard the launch event and I listened to the report, I knew that I could not be a passive recipient of another report talking about inequalities for minority ethnic women, whether they be staff or whether they be those using our services. So put myself forward to join in. And the ambition is really that through the forums that we're sharing this, we can enable all of those present, the leaders of midwifery services, to embrace the learning and take some positive action about these recommendations. So we are socialising it through social media as well, and we can be followed on Instagram, Facebook and Twitter so that we can percolate this across the country. Thanks. Next slide, please. As Tosin said, a lot has been done to address the issues around uptake of the COVID-19 vaccination, and 3 of the key leads held webinars about that, and this is the first of many collaborations on this project with the Royal College of Midwives and Janet File and also Suzanne, who I'm going to mention in a moment. Thank you. Next slide. Further women's forums have been held, and almost 200 women have attended, and we have worked in collaboration with 5 Times More campaign and the London Maternity Voices Partnership in order to be able to engage with the group that we're trying to hear from and are perhaps lesser heard. And we know that 5 Times More have got a really established network, and they're a great collaboration to be working with on this project. Next slide, please. The piece that I want to focus on that we've been working on as one of the work streams is career development. As Tosin said, one of the recognitions that's been established is that there is underrepresentation in senior level posts in midwifery from minority ethnic midwives, and we know that our workforces across the country do not represent the diversity of the communities that we are serving. So part of our work is to ensure that we are developing and nurturing the talent of colleagues in our teams whose heritage is Black, Asian or from a minority ethnic group. So some career development forums were set up and held, and again in collaboration with the RCM. Next slide, please. And a mentorship register is being established. This is the key piece of work, and I'm sorry about the time, but I would just like a minute to talk about this. We're working with the college to develop a mentorship programme for Black, Asian and minority ethnic staff, that's support workers and midwives. We have had 107 mentors sign up, and we've had so far 179 mentees want to join the register. We are developing a platform. It will be a digital platform, and mentees will be able to choose a mentor from their profile, establish an agreed relationship, set their goals, and be provided the leadership to aid their career development. This is not just for RCM members, this is for all maternity support workers and midwives, and the RCM are committed to that as part of their Race Matters campaign, and I think that shows testament from them to support this piece of work. We're going to be launching it in October as part of Black History Month, and then the final slide is just the next steps. I've touched on one about the mentorship platform. We're going to be piloting a social cultural maternity screening toolkit, more engagement with women and birthing people, collaboration with our colleagues and agencies, organisations, so that we're avoiding duplication and really bringing power to these pieces of work. Seek some external funding and start to initiate Turning the Tide 2. So just to say thank you, I'm sorry it's a whistle-stop tour. Please take time to read the recommendations that we've shared, and we welcome your ability to implement any part of this across your organisations, and also share with your midwives and your support workers these great resources that are going to be available to them. Thank you.
Thanks so much, Heidi and Tosin. Really appreciate the time, and that's a fantastic project. And you know, without a healthy work culture, we won't have healthy women, because we need to make sure that what we're doing is appropriate for our women by employing the right staff to be culturally appropriate too. So really great, and it'd be good to see some obstetrician up next to you as well, pushing this work forward, because we know we've got a multicultural group of obstetricians and gynecologists working with us, and it would be good for them to model too along with yourself. So thank you so much for that. We're going to be circulating the slides for everybody and the recording. I'm really sorry I've got to hop off now, but if there is any discussion that you want to make, please stay on the line. Gulna's still here. She can stay and support that if you'd like to do that. Otherwise, I'll wish you all every thanks for the presentation.